Okay, thank you everybody for joining us for this week's Miami Global Brain Tumor Symposium. My name is Mike Ivan. I'm one of the neurosurgeons here at the University of Miami, focusing on brain tumor and skull base, director of our research program. I'm joined today by my colleagues, Dr. Jacques Morcos, who is a professor and co-chairman of the department here of neurosurgery at the University of Miami. He's also the director of skull base and cerebrovascular. Dr. Komatar, who is professor and the program director of our residency program. He's also director of our Brain Tumor Initiative and director of surgical neuro-oncology. And Dr. Benjamin, who's assistant professor and a brain tumor and skull base expert, director of our skull base lab, and also part of our department here of neurosurgery. Each week we put on these brain tumor symposiums. I think this is week 14. And I cannot do it without the great help of our amazing administration team. They do so much behind the scenes, and they've really made this such a success. We've had over 4,000 views so far. Christina, Roberto, Ingrid, and Ignacio, thank you so much for all of your help. If you have any questions about our symposiums or our Department of Neurosurgery, you could always visit us on any of our social media outlets. We are on Twitter, we're on Instagram. We also have a YouTube channel where these videos are posted afterwards and you could view them. Or if you go to our website and to register for this symposium or other symposiums in the future at the address above. Quick shout out on Thursdays. We also have our cerebrovascular and skull base symposiums led by Dr. Morcos and the rest of the CV and skull base team here at University of Miami. This week, they'll be talking about embolization, preoperative embolization, in the debate format. So be sure to tune in tomorrow, same time, same location. Also, a quick preview teaser for next week, next Wednesday. We're inviting a special guest from Italy, Dr. Cavallo. Will be talking about endoscopic approaches for craniopharyngiomas and pituitary tumors, along with a great set of panelists. So please be sure to tune in next week. As far as this week goes, please, we try to make this as interactive as possible. Use the Q&A button at the bottom here, and we'll try to get to all of your questions that you may have. We don't offer CMA, but we will email you tomorrow or the next day with an email documenting participation. And please be sure to like, follow, and share our videos on YouTube, on Twitter and Instagram in order to increase our exposure and continue to share the knowledge from our great speakers with everybody around the world. So this week we have a great set of panelists welcoming Dr. Eric Mellon, who is assistant professor here at the University of Miami. He's in the Department of Radiation Oncology, one of the leaders of our neuro-oncology site disease group, and also the director of our radiation oncology research program. We have Carolina Benjamin, who's, as we said before, assistant professor here, and she's a brain tumor and skull base specialist, director of our skull base program. She also did a fellowship with Dr. Konzioka, specifically on radiosurgery, and Dr. Ray D'Amico, who joins us from Lenox Hill, director of neurosurgical services at Wyckoff, and part of their neurosurgery department as well. So thank you so much to the panelists for joining us and sharing their cases at the end of today's session. Today's special guest, we're very lucky to have him today, Dr. Sheehan, joins us from Virginia. And truly he is from Virginia. He got his master's, bachelor's, PhD, and MD all from the University of Virginia. He also has fellowships where he's done in New Zealand at the University of Pittsburgh. He's a brain tumor expert and even more so on radiosurgery. He's the Harrison Distinguished Teaching Professor in their Department of Neurosurgery, author of numerous books and manuscripts, over 400, a winner of multiple awards on brain tumor research, and he currently has an active laboratory that also focuses on translational basic science research on brain tumors at the University of Virginia, where he also oversees multiple clinical trials. He's on multiple editorial boards, but more impressively, he's the current editor-in-chief of the Journal of Neuro-Oncology, and he's also the current chair of the joint section on tumors for the AANS and CNS, which he's done just an outstanding job despite being during this tough times. So we're very thank you, Dr. Sheehan, for joining us tonight and for sharing us your knowledge on radiosurgery for METs.
All right. Hopefully you're seeing my screen and my PowerPoint by now. So first I'd like to say thank you very much. I think this has been an outstanding series of webinars and really an impressive educational feat that you've been able to accomplish in short order during this time of
Doctor, can you go to presentation mode, please? Go to presentation mode on the bottom right there.
To the COVID, in terms of the COVID pandemic, you've done an amazing job of stepping in to help to provide educational content for hundreds of individuals, including some of my own residents and fellows. So thank you. And I'm honored to be part of this. This talk is one that is a little bit different for neurosurgeons, although we did have a talk actually by you, Dr. Ivan, and Dr. Komatar on the Journal of Neuro-Oncology webinar series that is ongoing. I'll put in the shameless plug for that. But it's increasingly clear that neurosurgeons are playing an important role in the management of brain metastasis patients that is unlike any other impact that we've had in the past. Typically, neurosurgeons would play a role in the management of patients with brain metastasis, but it was much more limited. So if we look at the overall impact of brain metastasis, they actually far surpass primary brain tumors, including glioblastomas and meningiomas. On average in the US, there are about 170 to 300,000 new cases of brain metastasis each year. And keep in mind that the median survival of brain metastasis patients has crept up, and there are some instances where patients are living longer and that metastatic cancer has become almost a chronic disease state. Most of these patients still represent the primary histologies of lung, breast, and melanoma, but that there are other types such as gastrointestinal and more unusual types such as renal that may present to neurosurgeons to manage. If we look at this paper that was published in the Journal of Neuro-Oncology earlier this year, this is a probabilistic map of the location of brain metastasis in a large cohort of patients. And you can see that brain metastasis are not necessarily equally prevalent throughout the entire brain. Some of this likely has to do with cerebrovascular anatomy, perfusion, the milieu that is created by the brain for being hospitable or inhospitable for a metastatic lesion forming. Now, certainly I've seen metastatic lesions form in virtually every aspect of the brain, but these heat maps suggest that there are going to be differences even amongst histologies. As you can see, breast cancer distributions versus sarcomas versus pulmonary distributions. It's clear that the cerebellum is overrepresented, and that represents a challenge for neurosurgeons, obviously, because cerebellar and posterior fossa lesions do oftentimes present with some mass effect and even hydrocephalus. Breast and lung cancer lesions have a predilection for the frontal lobes in this study. So how do we look at patients with brain metastasis? Well, there are obviously some ways to stratify patients. You can stratify them based upon their colonoscopy performance status, the recursive partition analysis, GPA, or disease-specific GPA. And all of these have been validated through numerous studies, both retrospective as well as prospective. Or you could simply break it down to one lesion or more than one, and then stratify based upon performance, or even take your analysis to a further level, which is really to look at the genetic mutations and drivers. So let's look at the disease-specific GPA and survival. For non-small cell lung cancer patients with a disease-specific GPA that is somewhere in the order of 0 to 1, their survival is going to be only about 3 months on average. But if you factor in those that have EGFR or ALK mutations, and then have a disease-specific GPA for non-small cell lung cancer of 3.5 to 4 on presentation, their expected survival is nearly 46 months on average. It's a whole different patient population than these patients that have 2 or 3 months of median survival. So we've got to be specific on how we're stratifying patients and we have to understand where we want to use our most invasive tools or least invasive tools to managing the patients that are going to be short-term, intermediate, or long-term survivors. So first and foremost, whole brain radiation therapy. As I was a resident, we would typically get a call about a brain metastasis patient, and it was either do we operate and resect the tumor, or do we just send them for whole brain radiation therapy? Whole brain radiation therapy has been around for decades, and if you look back to the 1970s, that's where some of the earlier seminal studies on whole brain radiation therapy, 30 gray and 10 fractions, affording a median survival of 21 months in patients back in that era. Certainly, there's been no appreciable evidence to suggest that dose and fractionation schemes different from 30 and 10 gray meaningfully impact median survival in a large cohort of patients. Interestingly, in the contemporary era, the recent study, the Quartz trial, looked at patients who had best supportive care versus 20 gray and 5 fractions of whole brain radiation therapy for non-small cell lung cancer patients. And these patients were accrued from 72 centers and generally had a poor KPS. So the very patients that we might routinely give whole brain radiation therapy for. Interestingly, with best supportive care in the modern era, whole brain radiation therapy did not improve the quality adjusted life years or overall survival of patients, thereby questioning the value of whole brain radiation therapy in the contemporary era for the very patients that we most oftentimes use it for. So this is the Quartz trial and the overall survival. And again, the conclusion saying that there was no real benefit in this study for whole brain radiation therapy in terms of improved survival or quality of life or reduction in steroid use. And I think that those endpoints are pretty meaningful for patients that have survivals of 3 to 4 months. Do we put them through whole brain radiation therapy during that time frame, or do we support them with steroids and best supportive care? So what's the role of the impact of whole brain radiation therapy after, in terms of side effects? The whole brain radiation therapy side effects are very well described, and we published this paper in the International Journal of Radiation Oncology and Biological Physics, really looking at and stratifying leukoencephalopathy after whole brain radiation therapy or radiosurgery. In this case, grade 0 leukoencephalopathy was essentially little to no white matter changes, grade 1 a little bit more white matter changes, and grade 3 had pretty pronounced and widespread leukoencephalopathy. This color-coded bar graph shows very nicely as a function of time. Baseline, patients with brain metastasis had little to no leukoencephalopathy prior to whole brain radiation therapy or radiosurgery. Over time, at 1 year time point, you'll see that the whole brain radiation therapy arm had more higher to moderate grade leukoencephalopathies than those that were just treated with radiosurgery. And that became noticeably different at year 2 out from index ionization of ionizing radiation. And grade 3 and grade 4, the differences became even more stark, not just in terms of the overall prevalence of moderate to high grade leukoencephalopathies, but certainly the high grade 3 leukoencephalopathies at 3 years and 4 years out. It was most notable. Now, certainly not everyone's going to live 3 to 4 years out after whole brain radiation therapy, but as I did show, some patients will. Those that have favorable mutational status and relatively good performance status might very well live out to 3 years or beyond. We also looked at in this study at the integral dose, the overall amount of radiation that had to go to the whole head to precipitate higher grade leukoencephalopathies. Interestingly, giving a dose of 3 joules or more, in essence, a dose of 3 gray to the entire brain, which would be easily accomplished with whole brain radiation therapy, but seldom accomplished with radiosurgery, even to treat multiple brain metastasis, that threshold led to a higher risk of leukoencephalopathy, high-grade leukoencephalopathy developing over time. There have been some other studies. One of the earliest that points to the side effects of whole brain radiation therapy was Eric Chang's work when he was still at MD Anderson. At the time, he did a randomized controlled trial using the Hopkins Verbal Learning Test and really looked at patients who had limited brain metastasis who were treated either with SRS and whole brain versus SRS alone. Not surprisingly, the arm with the addition of whole brain radiation therapy had a substantially worse decline in their function, their learning and memory dysfunction at 3 to 4 month time frame. That risk was nearly twofold higher than with SRS alone. Another study that was recently published by Paul Brown and colleagues, NCC TG or N0574, really looked at patients who were randomized to either radiosurgery and whole brain radiation therapy. And the primary endpoint was cognitive function. And between the arm that had SRS versus SRS and whole brain radiation therapy, there was cognitive decline that was far in excess of when you added whole brain radiation therapy over SRS alone. That decline is noticeable not just at the 3 month time point, but even at the 6 month time point it persisted, thereby suggesting that the window that Eric Chang saw in his earlier study, published more than a decade before, actually lasts longer. It's not just at 3 to 4 months, but it's at 6 months too. And if you think about the median survival of patients with brain metastasis is perhaps between 3 to 12 months, this is really at the pivotal time frame for these patients where quality of life is essential, and that we're not doing them any tremendous benefit in many regards if we're giving a treatment that reduces their neurocognitive function at their median expected survival time points. Overall survival, interestingly, was not appreciably different from a statistical standpoint, but actually favored radiosurgery in this same study that Paul led. In a study that looked at resection and SRS or whole brain radiation therapy, this is really a study that randomized patients to salvage radiosurgery or salvage whole brain radiation therapy after radiosurgery. There was, in the two arms, roughly matched 130 odd patients. There was no difference in overall median survival. There was favored overall intracranial progression-free survival in patients who received whole brain radiation therapy, not surprisingly. But cognitive dysfunction was nearly twofold higher in the patients who were treated with whole brain radiation therapy over radiosurgery alone, and that was statistically significant. And this is just a little bit of that data here that looks at patients who were treated with the whole brain radiation therapy over versus radiosurgery, and this is overall survival. And then this is cognitive dysfunction. And you'll note that not only was the incidence of cognitive dysfunction at around the 90-day time point worse, but also the high-grade cognitive dysfunction was much worse in those patients that received whole brain radiation therapy. Shown here, there are 0 patients in this study that had grade 4 cognitive dysfunction, whereas there were 3 that had grade 4 in the whole brain radiation therapy arm, and 8 that had grade 3 cognitive dysfunction at 91 days after index ionizing radiation. So hope springs eternal. The radiation oncologist said, look, we can make whole brain radiation therapy better. And I submit to you that they can and did to a degree. One of the studies that was powerful in terms of showing intervention really was the addition of memantine to patients who had whole brain radiation therapy. These patients received memantine or placebo, and this study was published in Neuro-Oncology. It was a randomized trial with nearly 200 patients in each arm. And if you look, the placebo index shows cognitive dysfunction at 3 months out, hitting a percentage of about just over 50%, and the cognitive dysfunction in the memantine arm being well under 50% at 3 months. But if you'll note, it climbs up above 50%, even in the memantine arm at the 6 month time point. So it's not a magical cure when one gives memantine to patients with who are receiving whole brain radiation therapy. Certainly it is better for many patients and neuroprotective to some patients, but it's not a panacea to eliminating neurocognitive dysfunction after whole brain radiation therapy. Another approach that's been done, of course, is to more recently is to look at hippocampal sparing whole brain radiation therapy. And so this is something that's been touted as being a new approach. And so what is done is to give 30 gray and 10 fractions typically, but what you'll do is you'll carve out these areas shown here around the hippocampus and amygdala. And you'll see that these lighter colored, the more purplish and turquoise pictures are really the areas that are spared radiation to well below 8 gray in some instances. And so what they did was they compared patients who had hippocampal sparing whole brain radiation therapy versus patients that had memantine. And they looked at their neurocognitive function with Hopkins verbal learning. The same test that Eric looked at close to a decade and a half ago now, and looked at other cognitive function assessments. And the study shows quite nicely that patients who had hippocampal sparing, as indicated by this dotted line here, that they were less at risk for neurocognitive failure. But again, if you look at the 3-month and 4-month time points here, you're really at 50% or greater failure rate. But if you give whole brain radiation therapy memantine, that cohort did worse, suggesting that the patients who had hippocampal sparing whole brain radiation therapy and memantine, that the hippocampal sparing really did improve to a degree the neurocognitive function. But again, it's not a cure-all to these patients, and there is a significant rate, greater than 50% rate of neurocognitive failure or dysfunction at 4 months out, even in the patients that had hippocampal sparing whole brain radiation therapy plus memantine. So many of us know as neurosurgeons, and one of the running legends, and I will say that it wasn't, not only was it a legend, but it was a real story, is that my former chair held that every neurosurgeon had to understand and be able to describe Papes circuit. Memory is not just limited to the hippocampus and not just limited to the amygdala. And this is just showing some of the structures that are involved with memory. So if we're really just carving out the hippocampus and amygdala, it suggests a fundamental lack of understanding of the complexities of the memory function in the human brain. The Papes circuit, if you didn't know it and couldn't recite it, was one of the things that could get you fired as a resident, and that is a true story in my institution, although no longer. But it's clear that as a radiation oncologist, we should be thinking a little bit more broadly about memory structures, not just limiting radiation to those areas that are classical hippocampal structures and amygdala structures, but more broadly to the areas that are shown here and are known to be related to memory functions, and to really give radiation where it's needed in the human brain. So this is another look at the hippocampal sparing. And interestingly, again, we see cognitive dysfunction at greater than 50% in patients, even though they get hippocampal avoidance. And we know that there's although it will likely help some patients, that the benefits are likely realized greatest in those patients who are going to have a survival of more than 12 months. And you would think whole brain radiation therapy is relatively inexpensive, and that is true. But when you add hippocampal sparing, you've got to do a lot more to carve out those areas. So whole brain radiation therapy in 2014 terms costs about, an entire course costs about $6,500. When you add hippocampal avoidance to whole brain radiation therapy, it costs almost $10,000. For CMS patients, radiosurgery, stereotactic radiosurgery in 2014 cost about $9,000. And a follow-up MRI costs about $646 for CMS terms. So you can deliver radiosurgery and get one follow-up MRI for the cost of what it would cost to deliver whole brain radiation therapy with hippocampal avoidance. So I would submit to you that if you think that you have a patient that is going to live more than 6 months and they have limited intracranial disease, that there is a cost effectiveness to radiosurgery and a follow-up MRI, and conceivably using salvage whole brain radiation therapy alone or salvage radiosurgery than to give hippocampal sparing whole brain radiation therapy, which costs nearly $10,000 per course per patient. We did a study that looked at a meta-analysis that was published in Radiation Oncology Journal. Eric Lehrer and Dan Trifoletti joined me on this study. And we did a meta-analysis of patients that were treated with brain metastasis with hippocampal sparing, whole brain radiation therapy shown here in green, radiosurgery, memantine and whole brain radiation therapy shown here in yellow, or standard standard whole brain radiation therapy shown here in red. That was our reference for cognitive decline. And in the meta-analysis that we published, it was statistically significant in terms of reduction in cognitive decline with radiosurgery alone, even when you factor in patients who had disease progression after radiosurgery. So what are some myths about brain metastasis patients? I'm frequently asked about if there is a magical number by which one would withhold or not give radiosurgery. And, you know, sort of what's the holy grail? Is it 1, is it 3, is it 4, is it 5 brain metastasis? There was a survey that was taken at an annual meeting a few years back, and that survey of neurosurgeons asked the question about this very question: how many brain metastases would they treat? And the answer that was most prevalent in that survey, based that in the conference area with these handheld survey devices, was 5. Surprisingly, though, at the time that the survey was taken, there were no randomized controlled trials or strong high-level evidence to support the number of 5. But interestingly, that number of 5 was the limit to that which you could get reimbursed as a neurosurgeon for delivering radiosurgery to brain metastasis. But I would say to you now that I think that there is a tremendous amount of evidence to say that 5 is not the magical number, and that we are able to have higher levels of evidence to suggest that we can treat multiple brain metastases, more than 5, and offer and convey good value to patients in terms of local tumor control and progression-free survival. And radiosurgery devices now have almost allowed us to become limitless in the number of lesions we can treat and still afford a low integral dose. Remember, that links back to the risk of leukoencephalopathy and neurocognitive decline, to give a low integral dose to the entire brain. So that you can take patients like this that have 5 brain metastases, and these 5 brain metastases may be relatively small, 0.1 cc's, and the total volume of metastatic disease in this patient's brain is 0.5 cc's. Or you can look at someone who has 1 brain metastasis is 5 cc's and has a 5 cc total volume. Both may be asymptomatic. In this case, all 5 metastatic lesions are very easily treatable with radiosurgery. And in this case, this solitary brain metastasis that's 5 cc's is also generally easily treatable with radiosurgery. So that 5 or 1, you can easily treat these patients if it makes sense with the other factors involved with stereotactic radiosurgery as a neurosurgeon. Of course, you'll do this in a multidisciplinary fashion. Of course, you'll discuss this case, hopefully in a multidisciplinary tumor board. But these are patients that we can use radiosurgery, and that the number doesn't matter. It's really the volume that matters. And in this study published back in 2006 by my colleagues at Pittsburgh, what they found was that volume more than number was the single largest determinant for overall survival. And this has been shown time and time again in large prospective and retrospective studies. That is total intracranial volume that matters in terms of likely response, overall survival, and also risk of adverse radiation effects after radiosurgery. This is a study from 2004 team that really looks at the cumulative total volume. And with, as you go from 1 cc to 2 cc's to 3 cc's to 5 cc's, each one of these gradations leads to a slightly worse overall survival for patients. And that once you get above 10 cc's, the predicted survival worsens appreciably. Now, this isn't true for all histologies, and it does vary based upon histology, and it obviously varies now more than ever on the basis of the mutational status of the brain metastasis that were in the patients that we're treating. So it wasn't that long ago that this came out, and really this NCCN set of guidelines showed quite nicely that it's not so much the number as shown here, that it can be used for patients who have more than 3 brain metastases. It's really that SRS can be used as a primary treatment for patients who have good performance status and low overall tumor burden intracranial. Number, again, not a driving factor in these guidelines. So this video, which hopefully is showing okay, is a tail vein injection of metastatic cancer cells in an animal model. The red are the cancer cells as they get into the brain circulation, and then in a little bit you'll see the development of metastatic lesions, and those metastatic lesions are much fewer in number than the overall cancer that's been seeded into the brain by this tail vein injection. So this is, and here are the green structures showing the brain metastasis that have actually formed, demonstrable metastatic lesions that have formed with this tail vein injection. You can clearly see that not every metastatic lesion or metastatic cell that gets into the brain forms a metastatic deposit. So that we know that if we do modern volume acquisition 3 Tesla scans, pre and post contrast, that we can detect exceedingly small metastatic lesions on the order of 1 to 2 millimeters. Surveillance scanning allows us to detect patients both local and distant progression, and even their leptomeningeal spread if it were to occur, and we can intervene when appropriate. We don't need to worry about this concept of micrometastasis and that they're everywhere, because in many instances, these micrometastases never go on to form discrete macrometastasis, and they don't necessarily become actionable, at least with regard to a patient's overall survival and their performance status, as is shown by that animal model that I showed you earlier. It's really quite complex what is required to take a micrometastasis to become a macrometastasis. So if you look at the pre-metastatic niche here and the cancer cells through a leaky blood vessel in the brain, and this depicts melanoma cells here in black. And then what you have to see is an upregulation of GFAP, cytokines, and increased permeabilization of the blood vessels to form this macrometastatic lesion. And that it's really that in this study by Schwartz, published in 2016, it was roughly 23% of all micrometastasis went on to form macrometastasis in mouse models. So roughly 1 in 4. So that there are plenty of cells that can get into metastatic cancer cells that can get into the brain that don't go on to form macrometastasis that would require some form of intervention. So do we really need to treat these patients with micrometastasis? And arguably now, can we treat them with medical management, which I'll get into in just a bit. Certainly not all metastatic lesions need to be treated. Some metastatic lesions, even macrometastasis, are asymptomatic. And if patients are having progression of their extracranial disease, these patients can sometimes be followed with metastasis that may be sub-centimeter in size. And keep in mind that we're not necessarily curing these patients of their cancer as neurosurgeons, but we are providing a palliative service in many instances. I want to underscore that whole brain radiation therapy is not necessarily the wrong answer for some patients. And I want to be clear that although some patients will go on to experience neurocognitive decline, that risk goes up as a function of time after delivery of whole brain radiation therapy, and that not all patients who have whole brain radiation therapy, even without hippocampal sparing or without memantine, not all those patients will develop neurocognitive decline. So that in some instances, disease progression for patients intracranially is worse than the risk of delayed neurocognitive dysfunction. You really need to weigh the risks and benefits and have a candid conversation with the patient and their caregivers and family members. One of the things that we like to do around UVA is talk about Thomas Jefferson as sort of a living being and refer back to things that he said. And certainly I would say you could paraphrase some of his quote about all men being created equal. Certainly all brain metastases are not created equal. Outcomes vary tremendously, so that a 5cc brain metastasis that's EGFR has an EGFR mutation and metastatic non-small cell lung cancer is appreciably different than a gastrointestinal one, or a renal cell carcinoma one, or a melanoma one with BRAF mutation. Histological subtype, type of cancer, and genetic subtype has profound implications in terms of the patient's likelihood of surviving and benefiting from radiosurgery or benefiting from resection. In this work that was published in 2015, it's by Christiana Brastanos. It's clear that that the genetic mutations that are exhibited in the primary cancer cell and in the brain metastasis are not necessarily the same, and that there's a genetic drift between the primary and the metastatic lesions in the brain in many, many instances. And she showed this quite nicely, that the genetic mutations within the brain can sometimes be leveraged based upon the histology that we obtain from brain metastasis resections, and that we can't necessarily suppose that a mutation that could be a drivable target based upon extracranial disease histology is necessarily mirrored by the metastatic lesion in the brain and a targetable driver for the intracranial disease as well. It may or may not be, but in many instances, there's a genetic drift that goes on as the cancer forms in the brain. In this slide, this is a busy slide, but I want to spend just a little bit of time on it, and I'll just try to summarize it. It's quite clear that immunotherapy and targeted therapies are playing an increasing role in the management of patients with brain metastasis. And neurosurgeons need to have a primer on this. Targeted therapies are things like BRAF mutations in melanoma or EGFR mutations in non-small cell lung cancer or ALK mutations. These targeted therapies tend to have rapid effect upon tumors, even sometimes in the brain. They're rarely curative, and as soon as you discontinue the therapy, there's almost always a recurrence. These targeted therapies are increasingly frontline treatments for lung cancer patients. Immunotherapies, on the other hand, are things like your CTLA-4, ipilimumab, or PD-L1, Nivo, and Pembro, and they're really reserved at, they're much slower in onset. They're usually delivered for patients with melanoma as a first line, but not as a first line necessarily for patients with non-small cell lung cancer. Their onset of action in the brain is usually slow, and while the systemic therapy response may be curative, the intracranial disease is not typically curative. Discontinuation of the therapies doesn't necessarily lead to recurrence of the brain disease. There is variable penetration of immunotherapies into the brain, but there's much more commonly penetration of targeted therapies into the brain. And when we give immunotherapies, we don't want to give steroids very often, because steroids will compromise the effects of the immunotherapy, whereas steroids are perfectly fine in many instances with targeted therapies. So I think that these are very big, people will group these together and say, oh, well, we'll think about it. They'll even say targeted therapy / immunotherapies. These are distinctly different pathways and distinctly different patient types that you're going to want to use, and they have profoundly different effects sometimes in the brain. So here's an example of immunotherapy alone for small brain metastasis. They use immunotherapy for melanoma or non-small cell lung cancer. They took patients that had asymptomatic lesions that were 5 to 20 millimeters in size. The average was 11 millimeters for melanoma and 8 for non-small cell lung cancer. They gave Pembro every 2 weeks. The response rate was 22% for melanoma and 33% for non-small cell lung cancer patients. Interestingly, about 17% of patients that had melanoma developed seizures while on immunotherapy. No lesions that failed radiosurgery or whole brain radiation therapy responded to Pembro. So that, potentially radiosurgery is a good indicator of whether or not these patients are going to have a favorable intracranial response to immunotherapy, or at least in this particular study published in Lancet Oncology. Now, there are some instances where we'll consider using immunotherapies, systemic therapies alone for patients with melanoma. 57% of patients received local therapy alone. And these patients generally did pretty well, but these were patients that in this particular study published in the Red Journal in Radiation Oncology, these patients have to be followed closely. And typically you're going to be treating patients that have very small lesions and would be getting PD-L1 inhibitors regardless to control their systemic disease therapy. We looked more broadly at this review, and control rates ranged tremendously in melanoma for patients who were getting immunotherapies, ranging from 6.7% to 90%, but generally the rates were under 45% for largely untreated asymptomatic brain metastasis. This was a study that was published just earlier this year, or at least e-published, where they were looking at the effects of timing of immune checkpoint inhibitors and radiosurgery in a mouse model of metastatic cancer. And what they found was that the animals that were treated with radiation therapy followed by immune checkpoint inhibitors had a much greater upregulation of apoptotic genes. And you can see the list of genes that they were following here. And then patients who had immune checkpoint inhibitors followed by radiation therapy, suggesting that the radiosurgery or radiation therapy actually primes the cancer cells in advance to apoptosis when you follow it with immune checkpoint inhibitors. And this mirrors a little bit of some of the work that we've seen in other forums. So if we look at what's the rationale for postponing radiosurgery and in patients who have non-small cell lung cancer patients with EGFR mutations who just received tyrosine kinase inhibitors alone. This study that was published in JCO shows quite compellingly that patients who had upfront radiosurgery were far more likely to have a better survival, as shown here in the blue line, than patients who were treated with salvage radiosurgery or just had upfront EGFR tyrosine kinase inhibition. So don't delay the radiosurgery in patients, at least patients that have EGFR mutated non-small cell lung cancer. And then we looked at, and this is a multi-center study that my group published and is due out in Journal of Neurosurgery. Matt Shepard was the lead author in this. He's now at MD Anderson doing his fellowship. Matt looked at checkpoint inhibition in non-small cell lung cancer patients. And we found that patients who had checkpoint inhibition within a couple months of the time of their radiosurgery were far more likely to have better survival, shown here with the Kaplan-Meier plot, and overall better intracranial tumor control. In this meta-analysis that we did and published, Dan Trifoletti, Alfredo Quinones, Eric Lair, Jennifer Peterson, and I published in Radiation Therapy and Oncology. We looked at and did a meta-analysis of patients who were receiving immune checkpoint inhibitors with brain metastasis who underwent radiosurgery. And it is clear that patients who get concurrent immune checkpoint inhibitors with radiosurgery tended to do better in terms of overall survival. And that's the green line here. Those that got immune checkpoint inhibitors before radiosurgery or those that got them substantially after radiosurgery did more poorly. And this was really within about 30 days of getting their index radiosurgery. So there's a synergism between immune checkpoint inhibitors and radiosurgery, possibly related to that upregulation of apoptotic genes, possibly related to some other priming. But it's been shown time and time again, both in animal studies as well as human studies. And we really looked at looked at 1-year survival and looked at the response rates in terms of local tumor control. In terms of radionecrosis, there was no appreciable increased risk with concurrent immune checkpoint inhibitors and radiosurgery. If one gave immune checkpoint inhibitors at or around the time of radiosurgery, the risk of radionecrosis was still quite low. So another thing that I'll embrace fully is this idea that as neurosurgeons, we tend to think about radiosurgery in a very Lexellian fashion. There's single fraction radiosurgery, and then there's everything else. But radiosurgery is really 1 to 5 fractions, and typically at high doses. How high? Usually 5 gray or more per fraction. And we don't always need to give single fraction radiosurgery. In this case, by Benetti et al., published in the Red Journal in 2016, they saw a survival advantage to multi-fraction radiosurgery in terms of a reduction in the risk of radionecrosis. And here what they were doing, were giving hypofractionated radiosurgery, three fractions of 9 gray, and compared that to a matched cohort of patients who had single fraction radiosurgery. So there was a reduced risk of radionecrosis with hypofractionated radiosurgery in this series. And then it's also clear that radiosurgery, this sort of 3 centimeter rule of thumb, that we don't need to just use radiosurgery for patients that have small brain metastases. Larger brain metastases greater than 3 centimeters can be treated. We can do staged radiosurgery. The Cleveland Clinic group is doing this and showing quite nicely that they can treat a patient with 1 stage and then a month later treat the patient with a 2nd stage of radiosurgery to the same lesion and get a favorable local tumor control response and a low risk of adverse effects. Or you can do hypofractionated radiosurgery like I just showed you. So if you look at here's some fractionated radiosurgical series. This is from the Gamma Knife literature with 2 or 3 stage radiosurgeries for large brain metastasis. And if you look here in this column, that the tumor volumes 11 cc's, 21 cc's, 16 cc's on average, but some that were in the 30 to 60 volume range. Now, I'm not typically going to advocate for radiosurgery with a 60 or 70 cc tumor, but at least some have done it and done so in a 2 or 3 stage radiosurgical approach. And the complication rates in these series were single digits, that the survival was pretty favorable, albeit with a heavily selected patient cohort, and that the risk of intracranial death from disease progression was less than 20% in all but 1 series. But this is a little bit like the Wild West. We don't really know exactly what the right dose and fractionation scheme is. Should we be doing staged or hypofractionated approaches? There's plenty more data that's coming out, both in hopefully in terms of randomized controlled trials or in terms of retrospective registry-based studies. We don't want to be like Clint Eastwood and just pick random dose fractionation schemes here and shoot at the metastatic lesions necessarily. We've got to use a systematic approach. But here's an example of a large metastatic lesion, left temporal region. This had a tumor volume roughly of about 18 cc's. You can see nice regression over time out to 1 year. And dose fractionation schemes that we'll routinely use are 8 gray times 3 or 5 to 6 gray times 5. This is a study that was published by Arjun Segal's team in the Red Journal, and it's really an interesting idea. and one which I'd submit we might need to think a little bit more about applying in a clinical arena. And what they did was they looked at the brain volume receiving greater than 30 gray in hypofractionated radiosurgery to brain metastasis patients. So what they did was they took the volume of the brain that received, the entire volume of the head that received 30 gray, and subtracted out the volume of the tumor that received 30 gray. Because it's not so much that you're not so worried about adverse effects in the tumor. Metastatic lesions don't typically have brain within them. It's the brain that's around them. So you want to look at the brain, the dose that's going to the brain tissue around them. So they subtracted the metastatic lesion volume from the V30, the volume of brain that was receiving 30 gray. And what they found was that the magic threshold here was that if you exceeded 10.5 cc's of brain in this 5-fraction radiosurgery algorithm, 6 gray times 5 fractions, if more than 10 cc's of brain received greater than 30 gray, the patients had a greater risk of adverse radiation effects. And overall, their risk of adverse radiation effects treating some fairly large metastatic lesions was only about 11% in this published study. But we probably need to be looking not just at the 30 gray volume in the head, but the 30 gray volume of brain tissue and what that threshold is. So I'm just going to conclude by saying that I think that now more than ever, neurosurgeons are playing a larger role in the management of patients with brain metastasis. We're involved in their resection, and we always will and should be. I didn't touch upon this much, but we just had a very nice Journal of Neuro-Oncology webinar by the Yale group. We're involved in their management of brain metastasis patients, and I know the Miami group does a lot of this as well with LIT. We're certainly heavily involved in their management of patients with radiosurgery for new metastatic lesions, commonly for 1 to 10 or even sometimes more than 10 lesions. We're involved in treating patients with radio-resistant metastasis like renal cell carcinoma and melanoma. Radiosurgery is excellent for patients with eloquent areas. We published some studies on that, looking at eloquent region brain metastasis. I didn't get into it in the interest of time. Larger metastatic lesions greater than 3 centimeters of maximum diameter and resection cavities are very good targets for radiosurgery, either single fraction or hypofractionated. Certainly, we can think about and use whole brain radiation therapy for patients that have poor survival, but weigh that against the best supportive care and the Quartz trial data that's come out. We need to be very circumspect about when we do whole brain radiation therapy. Leptomeningeal disease, a little bit complicated, but oftentimes treated with whole brain radiation therapy, although there's some emerging data for treating certain types of leptomeningeal disease with radiosurgery. And chemotherapy, immunotherapy, and targeted therapies, that's, as I indicated to you, an evolving and expanding role for the management of brain metastasis patients, and really suggests that we need to be looking at these patients in a multidisciplinary fashion. Neurosurgeons need to have a seat at the table for every brain metastasis patient that is coming through our academic institution. We weigh the impact that neurosurgical tools can have on these patients. So I thank you, and this is a picture of UVA and the lawn with Jefferson's Rotunda. This is the original part of the university that he helped to build in 1890. So thank you very much.
Thank you. Thank you so much, Dr. Sheehan. That was a great review and coverage of all the current literature going on in radiosurgery for METs. A couple questions. One was that came up earlier was radiosurgery for pediatric populations. Is that something that's, obviously we don't see a lot of METs in the pediatric populations, but do you think that the same kind of outcomes as far as whole brain radiation versus radiosurgery for any intracranial lesions for kids is similar data that supports what you showed today?
Well, another aspect of another intracranial interest of mine is AVMs, and I would say we have a huge experience and have published pretty extensively in stroke and in Journal of Neurosurgery and Neurosurgery. neurocognitive function is maintained in patients with pediatric patients who are getting treatment with radiosurgery for AVMs. Now, we don't see very many patients with brain metastasis who are pediatric in age. It would be extraordinarily rare, but it is quite clear from the literature that proton beam has some advantages for patients. The St. Jude's group has looked at that. Other charged particles are being considered. But in pediatric patients, we want to be very, very circumspect, very careful about ionizing radiation in the developing brain and the potential long-term effects, not just neurocognitive, but also potential radiation-induced neoplasia that can arise and other latent effects that can arise after decades or more after treatment.
When you're looking at the quality of life and cognitive outcomes, do you feel like that grouping the patients who have good control in their brain and people who have progressive tumors in their brain should be kind of grouped into the same quality of life outcome and cognitive outcome patients when we look at these like large studies? Obviously, larger studies, when you have many patients, you should accommodate for that. But do you think that looking at maybe patients who have well-controlled disease and comparing those would be more useful as far as understanding these studies that are now looking at radiosurgery for 15, 20, 25 mets and where that threshold is?
Well, you're absolutely right. And you ask a very relevant question. It is clear that progressive intracranial disease is a neurocognitive, a threat to neurocognitive function. We just have to make sure that, but not all progressive disease is. Some is, some is not. It depends upon the extent, the location, and the survival of that patient. If they have a 5 millimeter metastasis and they end up at 3 months and they end up dying at 6 months, it's unlikely in my experience that 5 millimeter metastasis is going to be an imminent threat to their neurological function. It may be, but it's not likely. But we've been part of the NeuroPoint Alliance Radiosurgical Registry. We have about 8,000 patients accrued now. We're following those patients prospectively using the EQ-5D score, working with colleagues at the Mayo Big Data Institute, and we'll have some papers coming out that look at brain metastasis patients in a prospective registry and have very detailed EQ-5D data, really looking at subsets of those parameters. We published a little bit on that from our institutional experience, and there are subcomponents of the score so that not everything changes the same in the same fashion. Patients do have some improvements in some memory function, but interestingly, their depression scores after radiosurgery remain pretty fixed. And I think that's part of what we may need to consider managing in a multidisciplinary fashion, even engaging our medical oncologists and palliative care doctors about for instance, prescribing antidepressants for patients in some instances who have brain metastases and are clinically depressed, where we can make a meaningful improvement in those. But I think there's much more that can be done, and that these tools, the Hopkins Verbal Learning Test, which I've talked about a lot in some of these studies, is used by Paul Brown's group and Eric Chang's group, and the EQ-5D scores and other sorts of things, are all being applied prospectively to patients in clinical trials and some in the registry initiatives I alluded to. So I think we'll have better data as time goes on.
Sure. So it's already 6. Dr. Mellon, do you want to show your case?
Certainly, happy to. Thank you, Dr. Sheehan. I'm just going to play your YouTube, presentation on YouTube to the Rad Onc residents, and I'll just step out. But absolutely.
Just as long as you don't throw anything at me during that.
So let's see.
Yeah,
it's the wrong one. Give me one sec here. There we go. So This is going to overlap a little bit with Dr. Sheehan's talk. I was asked to present an interesting case, and this is something that I found particularly interesting since I started here. We've had a number of patients with large unresectable brain metastases, and what do you do for those cases? I was a bit up in the air, just as Dr. Sheehan was saying. It's the Wild West out there. When I first started as an attending, and I started getting these cases, and you do a literature review, everyone does something different, and the data is very all over the place. And so the example case I have for you is a 38-year-old woman with a high performance status. She only has one metastasis in her body at the time, and her basal ganglia is shown, measuring up to 3.2 centimeters. From an ER/PR negative HER2 positive breast invasive ductal carcinoma, and she was on HER2 maintenance therapy only. She had a symptom of just persistent mild headaches that led to this MRI, and when she was started on steroid, her headaches went away. But of course, we saw this MRI and wanted to intervene. So for radiation therapies, Dr. Sheehan mentioned, you can do single fraction stereotactic radiosurgery, 3-fraction fractionated stereotactic radiosurgery, or 5-fraction fractionated stereotactic radiosurgery. And the answer, and even the dose for what you would give for this depends on your institution and the individual radiation oncologist and neurosurgeon on the case. And there's many possible doses and fractionations that people use for these. Single fraction radiosurgery for large brain metastases. The RTOG 9005 was a dose finding trial for stereotactic radiosurgery. All of those patients did have prior whole brain radiation. And 2/3 of those patients had brain metastases, 1/3 actually had glioblastoma. And they looked at what the toxicities were of the stereotactic radiosurgery. So in patients who had a maximum diameter of brain metastasis up to 4 centimeters, between 3.1 centimeters to 4 centimeters, they received 15 gray. They had different dose levels, and they de-escalated to 15 gray, and they found 14% non-reversible grade 3 or any grade 4, grade 5 toxicity. So that's at the standard for single fraction dose for these tumors, and it really hasn't changed over many years. The Maniti data, this is the same data Dr. Sheehan referred to earlier, showed that 1-year local control for these patients with brain metastases 3.1 to 4 centimeters treated 15, he did 15 to 16 gray, but 15 to 16 gray single fraction was only 54% at 1 year local control, and a large percentage of them, 33%, had at least imaging evidence of radiation necrosis. The Alliance trial, the intergroup, I should call it, trial that Dr. Sheehan had referred to earlier, excluded brain metastases above 3 centimeters. And the current trial, which I should mention, NCIC-CE7, which is available through a number of cooperative groups in the United States. NCIC is the Canadian group, but it's available in the United States as well, is radiosurgery versus whole brain radiotherapy with hippocampal avoidance for 5 to 15 brain metastases. And I would strongly encourage anyone on the call to enroll on that trial so we get an answer. There was the trial, the NCCTG trial that I list was 1 to 4 brain metastases. 5 to 15 will be the CE7 trial that's currently underway. And both of those trials basically just excluded large brain metastases, I think in large part because of the volume question. These large brain mets tend not to do so well, and they wanted to answer that question of number, not volume. So the control, as I mentioned, is not very good for single fraction. This was a review in 2011, but really the data has not changed significantly, and I think they plotted this out very nicely. You have diameter on the x-axis, and what you can see here is that for large brain metastases, 3 to 4 centimeters receiving 15 gray, the control here on the y-axis is typically on the order of 40 to 50%. Meanwhile, fractionated stereotactic for large brain metastases, there are numerous studies with mixed doses and techniques. In the Southeast, at least, and also Dr. Sheehan presented Arjun Segal's data that was very recently published. We tend to use 5-fraction radiosurgery techniques, though in Europe and parts of the United States, 3-fraction is more common. So University of Alabama published their 5 fraction series. And they had 36 lesions greater than 3 centimeters in size. They had treated them with 25 gray and 5 fractions and 30 gray and 5 fractions and found much increased control with 30 gray and 5 fractions and with low toxicity. So what limited data there is would suggest much higher control with fractionated radiosurgery versus single fraction with controls in the order of more like 70% plus. So why might fractionated stereotactic be better in these large brain metastases? Well, late effects of radiation, like radiation necrosis, are thought to be correlated with higher doses per fraction, whereas tumor control is not as sensitive to high doses per fraction. And so in the radiation oncology world, the way we normalize doses is based on something called the linear quadratic model, which I don't have time to go into. But it essentially gives you a way of normalizing different doses. And so for an SRS dose of 15 gray in a single fraction with a BED of 10, which is an estimate for tumor control, you have this number, this relative number of 37.5, which is equivalent to 25 gray and 5 fractions, which we consider a fairly low dose. Now, the dose that you need to get good control, at least in the radiation oncology community, we generally think of 20 plus gray to get durable control of brain metastases. We typically deliver those doses to smaller brain metastases, but for a BED 10, that's a dose of 60 gray. Now at 18 gray per fraction, which is also a reasonably high dose, which we're more comfortable with, it's 50.4 gray. Now for late effects, that is radiation necrosis, you get these other numbers, 127.5, 180, 220. Now compare this to fractionated. If you wanted to give, say, 60 gray tumor dose, 35 gray and 5 fractions get you there. And the late effects dose, the radiation necrosis causing dose, is much, much lower. And so we think that the right dose in fractionation to give you equivalent to 18 to 20 gray is somewhere in the order of 30 to 35 gray and 5 fractions, which again, for if you're doing 15 gray and 1 fraction, 127.5, you can get 30 gray and 5 fractions in there for the same risk of toxicity, but with more control, with this more on the order of 18 gray and 1 fraction. So we do know from the fractionated data, this is a meta-analysis in 2017, that the higher the biologically effective dose, that dose I've shown you before, again, to normalize all these together, the more control you get, where these blue lines are increasing control with more dose. And again, this is 35 and 5 up here, and it continues to go up. Excuse me. So, there is currently a fractionated stereotactic trial for cavities. They are randomizing single fraction radiosurgery to fractionated radiosurgery. So this is for resected metastatic brain disease. Arm A, depending on the size of the resection cavity, gets 12 to 20 gray in a single fraction. Arm B gets 27 gray and 3 fractions, or 30 gray and 5 fractions, depending on the size. Large cavities get the 5 fraction regimen, smaller cavities get the 27 gray and 3 fraction regimen. And I highly encourage everyone to enroll on this trial so that we'll know the answer really is the fractionated better than the single fraction in resected brain disease. And this is run by Dr. Brown from Mayo through the Alliance Group. Now this is for resected brain metastases. What about for large unresected brain metastases? Well, that patient I showed you, as well as some other patients, led me to ask the question, what do I do for these patients with intact brain metastases? And so what started as a dose-finding trial for large brain metastases has sort of morphed into a randomized trial of single fraction radiosurgery versus multi-fraction radiosurgery for large intact brain metastases. And this has been approved by the Alliance Neuro-Oncology Committee, and we're trying to get it through the clinical trial evaluation program now, but it would be for unresectable or partially resected, that is, there's still gross residual disease, brain metastases or a combination of metastasis and cavity greater than 3 centimeters. And you could treat some additional metastases that are intact as well under the protocol. There are some other details, but with the endpoint being 1 year local control, we'd look at toxicity, overall survival, and then do some corollary objectives as well. And this is with a lot of help from Paul Brown and mentorship from him. So technical note, of course, delivery of fractionated stereotactic radiation is becoming more popular among radiation oncologists, giving the retrospective data indicating improved outcomes. And this implies a frameless setup, right? Because you don't want to put a frame on someone and treat them 5 times. Because you have to put the frame on 5 times, right? So it implies a frameless setup with either a gamma knife icon system, a cyberknife system, or an SRS-capable linear accelerator setup. So we have a gamma knife perfection system here at UM, but for these, we use a linear accelerator-based setup. So what about our case? This patient was treated in February 2018 with 15 gray in a single fraction by myself and Dr. Rick Komatar. And I'm happy to report this patient has had no further systemic disease, is doing extremely well, has no symptoms of this, and there's a stable tiny residual, and she is doing great and is very happy. So maybe a single fraction is just as good. This is the problem with retrospective data, and I'm hoping that we'll get prospective data.
It's a great response and great talk.
Thank you.
All right, thanks so much, Eric. Yeah, that was really informative. Randy, you want to go next?
Yeah, you want me to go next?
Sure.
Jason, great talk. Good to have your expertise in this matter here. And Eric, actually, I'm curious to see your thoughts on this as well. You know, so at Lenox Hill, we've got excellent radon team.
There, Randy.
Let me try one more time. Hold on.
Yeah. There you go. Thanks.
So at Lenox Hill, you know, we've got a great radon team, and you know, we have a great program, multidisciplinary, obviously neuro-oncology program. But at the other hospital I work at, it's a smaller community center, and we're actually we have everything that we need. We have radiation oncology, we've got oncology, we've got neurosurgery now since I joined. But we're probably one of the youngest oncology groups in New York City, dealing as a group. And so your guys' expertise in these situations are super appreciated. But what I'm presenting here is a 61-year-old woman. She had a history of a melanoma resection in 2018 on her shoulder. And she had, you know, complete resection and no further treatment. And developed basically 3 months or so of worsening memory, some headaches, and then really a subacute decline over the course of a week, where she was just sleeping around the house all day. When I met her, she was actually in distress. She was, you know, drowsy, somnolent, lethargic. She was anti-gravity and following commands, but with a lot of stimulation. And so this is her scan. And you saw she had 3 large right-sided lesions, 2 right frontal, 1 right parietal. The right frontal lesion along the skull base there had bled a little bit. But what you can't see on this scan is that she also had a small left-sided lesion, so a total of 4 mets. And so the initial discussion here, and it's definitely, you know, controversial, but I ran it by people, is that her surgical baseline was actually fantastic. She's fully functional. She had no systemic disease on her systemic workup. And we decided, and these were, you know, surgically accessible lesions through really 2 approaches, knowing that we were going to leave the left frontal lesion and then be left with the cavities to deal with as well. And so we took her for surgery. I did it, you know, 2 approaches, got all 3 lesions from the right side, and left the left-sided lesion for radiosurgery in addition to the cavities. And pathology was melanoma. PD-L1 was less than 1%. It was BRAF mutated, PET negative for systemic disease. We followed up the CT scan. And we decided, again, on the targeted therapy, dabrafenib, even though there is some evidence, I guess, that IPI would have worked here as well, because the PD-L1 percentage doesn't matter as much. And then radiosurgery. Now we have a LINAC-based fractionated system out in Brooklyn. And, you know, this case to me raises a lot of questions, and I'm curious on your guys' opinions and just really the discussion. So post-operatively, she did fantastic. KPS, you know, 90 or above. She looked perfect. And the question is here, you know, what are our options and what do we do? So we've kind of discussed the issues with whole brain. This is a treatment-naive woman with, you know, large mets, but, you know, she's never, and no systemic disease. Do we put her at risk of the cognitive deficits with whole brain versus stereotactic? Obviously, a LINAC-based system that's fractionated versus a single fraction, which I think we've discussed now, kind of the benefits and alternatives of. And then the other issue here, and this came about after a discussion that Jason and I have had in our other webinar with the Journal of Neuro-Oncology webinar, is the timing of immunotherapy in these situations and kind of the broader discussion of what you do there. So I'm curious to have you guys chime in. This is a recent case, so I don't have great outcomes like Eric showed, but we can at least talk about some of the controversial points.
Well, I think Dr. Sawaya and others have shown quite nicely that in instances where patients have surgically accessible lesions, metastatic lesions, like you demonstrated, that and they've got reasonable performance status prior to their presentation and well-controlled systemic disease, that doing what you've done in terms of resection is a very reasonable approach, especially when you could deal with most of it through two approaches. And then I agree. I mean, I think leveraging off the BRAF mutation makes sense for treatment, and I would think about radiosurgery to treat the resection cavities in the left frontal lesion. There are some studies that look at the dynamic changes of resection cavities, and Dave Larson and the UCSF group published some work on that. Also, the Dartmouth group has. So typically, I wait about 2 weeks after a resection cavity if I can, because that will collapse and decrease your volume. But I think it's worth radiosurgery on this patient. Probably would fractionate it.
Yeah.
Well, I'm not sure what
Eric,
Michael
what do you think?
or Eric would do.
Yeah, so yeah, there were several fairly large lesions, correct? So I tend to avoid surgery in those unless there's one dominant one that's causing symptoms. So then we're talking about radiation, obviously. And then there was a trial that was presented. I don't recall if it's been published, but there's a trial presented at last year's ASTRO, the RADONC conference, that was for SRS versus whole brain, specifically in melanoma brain metastases out of Australia, where they see a ton of melanoma. And there was zero benefits of the whole brain, not even in progression-free survival, which is typically where you see the benefits of whole brain, because it's a radio-resistant tumor. So I do everything I can not to whole brain metastatic melanoma. I almost never do for that reason, even in a scenario like this, because I just don't think it's going to respond. So then I would recommend SRS. I agree. I'd probably do fractionated for large volumes like this. And as far as timing of immunotherapy, I'm a believer in trying to trigger the abscopal effect. I'm not entirely clear if it's a real thing, but I would like to if it is, and if I can get that, I would like to. So what I usually ask the medical oncologist to do is start the immunotherapy either before or the same time with the start of radiosurgery, if at all possible. And for that potential synergistic effect as well, there was, Dr. Sheehan presented sort of the meta-analysis for brain metastases getting immunotherapy. I like to cite the Talby study. There was specifically a study out of MD Anderson that was for combination immunotherapy. I believe it was Ipi-Nivo. For metastatic melanoma as a phase 2 in patients with known brain metastases. And the response rate wasn't great. The actual response rate was in the 30%, but there was a decent stable disease as well. So maybe the synergy of the two, of the SRS with the immunotherapy, will give the 1-2 punch to hopefully get these under control.
Yeah, and we actually spoke about that. I have a slide about it, and this was something by Dr. Wegner's group, where similar to what you're saying, they looked at whole brain versus immuno alone, and in combination, actually the combo group did worse, but stereotactic with immuno did a little bit better. And we discussed at length kind of the synergistic effect, the abscopal effect that you mentioned, and that's prompted some further looking into this as well in terms of timing. So we'll see what the outcomes of that are.
Great case, Randy.
Question: You have an icon there?
No, so at Lennox we do. In Brooklyn we just have a LINAC based.
Okay.
Fractionated. So fractionated was all we could do there. Yeah.
Yeah, I agree with the resection for these patients. I mean, as we're learning for both glioblastoma and Mets, I think when they're accessible, like Jason said, accessible, good KPS, controlled systemic disease, and doing well. You know, whether there's multiple or one lesion, if you could get out the large majority of the tumor volume, of the overall cranial volume with surgery safely, you know, we tend to be aggressive with that. I just had a case similar to this, but it was breast, 2 occipital lesions, both around 3 centimeters for somebody with newly diagnosed breast cancer, and a small frontal lesion. And the same question came up is, you know, do you resect with 3 lesions or not? And we decided to elect to resect just because it was a young patient, no systemic disease, first time diagnosis, and we felt that would give her the best overall, you know, possibility of saving her vision, and we were able to do that. Okay, Carolina.
With a BRAF mutation, you may see a very favorable response in this patient. And also, I think that when you treat that resection cavity, you want to put a little bit of a margin around the resection cavities, unlike what you might do with a discrete unresected tumor. I don't want to digress too much, but there's this controversy about. I'm curious what Dr. Marcos or Dr. Ivan or Dr. Benjamin think about pre-resection radiosurgery.
Yeah, I mean,
do you do any of that in Miami?
We discussed it often in our tumor board with Eric and Tejan, and the idea of being able to identify the cavity more thoroughly, to get the margin more thoroughly, is definitely attractive. But you know, many times when we're talking about resection, you're talking about larger lesions, and then that becomes a question of, is the amount of radiation to that surrounding brain, you know, worth the benefit? Eric, Carolina, Jacques, any comments?
I look forward to there's a trial pending on this topic as well. I look forward to that trial. Logistically, it's hard because you have a lot of time in the post-op setting to sort of get the patient teed up and get things scheduled and everything. In the pre-op setting, it's a rush. I mean, it's an urgent situation oftentimes. So it's more challenging logistically. And I think that's one of the major reasons we have not done it here. Also, our bet, you know, it's like we have a combination of radiosurgery systems, some of which are at the hospital, some of which aren't, but we will be upgrading our equipment at the hospital, so we'll have all the options there. So I think at some point we will start doing some pre-op cases in the future. And there is this balance of, just as Dr. Ivan was saying, you've got the balance on the one hand of the cavity may shrink after treatment, but then the problem is it becomes more nebulous as well. So now you've got like fuzzy borders, and so sometimes it's hard to really define the cavity, so you end up putting a margin on that and treating more brain versus a larger target up front. And then the benefit of pre-op as well, that we think, is reducing the risk of leptomeningeal disease, which you can get which is about 15 to 20%, something like that, after surgery, versus in the intact setting is much less common. So benefits, and benefits, pros and cons.
I think conceptually, I kind of like the idea, especially because we do see sometimes you'll see this sort of like focal dural spread, or even a distant dural spread, and you got to think, well, what if we've given the effect beforehand? Would that have made a difference? It's tough to know. And I think logistically, you're right, Eric. Like it's kind of tough, but you want to be able to get a system where you have these people, treat them, and then inpatient, same hospitalization, take care of it. So I think conceptually, I kind of like the idea of it.
Okay, Carolina, you want to show your case real quick in the last few minutes?
Absolutely. Dr. Sheehan, thank you so much. It's nice to finally meet you. I think we've been on some papers together, but I've never officially met you. So
delighted to meet you. Thanks for joining.
Great talk. So actually, I'm going to present a case that I did in my fellowship with Dr. Konziolka. And so it's an interesting thing, and I'm actually glad, Eric, you touched on the topic of the very large brain tumors, because I'm very curious to see some of your guys' thoughts on this. So she's a 69-year-old, 50-pack year history smoker, presented with imbalance and incoordination. And on workup, she was found to have EGFR negative, ALK negative, PD-L1 0%, non-small cell adeno. And she had undergone a lung biopsy. She had a severe, sort of pretty bad metastatic disease, but from a neurologic standpoint and KPS standpoint, she was doing very well. Only thing was she was slightly, maybe a little bit more, less active, not necessarily somnolent, but less active than she had been previously. So this is in addition to these large tumors, the sort of deep, high cerebellar one, as well as this basal ganglia putamen one, she also had 2 other small lesions. These are the volumes here, as you can see. And I'm curious to see what you would say about this, Dr. Sheehan.
Well, these developed while she was on Keytruda too, right?
Well, this was at diagnosis. She was started on Keytruda, but this was at diagnosis. Yeah, she was treatment naive.
Yeah, certainly I'm concerned about the posterior fossa lesions. It looks like she's got compression of her 4th ventricle. I would be worried about this patient, and probably, I think you consider the option of resection of the posterior fossa lesion.
Yeah.
The concern, of course, is that if you don't, you'd have to at the very least, and the larger. It looks like she's got a smaller one on the left vermis there.
Yeah.
So I think I would strongly consider resection of that. It is 16 cc's. If you decided to treat it with fractionated radiosurgery, I would feel almost certainly compelled to shunt the patient in advance, because I don't like the degree of compression on the 4th.
Right.
And then the caudate lesion, I think, is potentially manageable. It's a very similar case to what Eric showed, although different histology. But I would probably hypofractionate that one, and rather than doing single fraction, I would do 3 or 5 fraction to treating that. But we've got 2 large ones and a 3rd smaller one in the left cerebellum.
1 additional small one, higher up.
Okay. Yeah, I mean, I think the small ones are very manageable with single fraction, and you can mix and match your radiosurgery. In other words, you could easily integrate into the same radiosurgical plan and calculate the total integral dose and dose to critical structures, developing a plan that would, for instance, treat the larger caudate lesion with one with 5 fraction radiosurgery, treating all the smaller ones, which I would do not with 5 fraction. I would do those with single fraction radiosurgery. But I guess the real question is what to do again about that posterior fossa lesion. I'd be interested to know what others on the call would do: resection, shunt, or some combination.
What was the histology again, Carolina? I'm sorry.
Melanoma?
These are melanomas as well.
Lung.
Oh, it's lung.
Oh, lung. Okay.
So this is one, the reason I asked that question is this is one where I would strongly consider whole brain, actually. Try to shrink these down. For a radio-responsive histology, you might actually get a decent response, and then you can follow up with an SRS boost later.
Okay. Mike?
And you said these are progressive, right, Carolina?
No, so
on treatment?
No. She's treatment naive at this point.
Okay.
Yeah, I mean, I say the same concerns of Dr. Sheehan. I actually have a similar patient that this is ongoing right now, where it's again breast but not lung. But we decided to go forward with radiation first with close monitoring. But 2 months after radiation, she ended up needing a shunt because developed some headaches, and so we ended up shunting her, with just very minimal symptoms. Like she's like, I have a headache, and we got a scan, and it was the tumors hadn't shrunk, and we decided just to kind of almost prophylactically shunt her. So we just did that yesterday, and the hope is that the tumors will continue to grow. But she has about 7 lesions, whereas this patient has 4. But still, I'm most worried about the one that Dr. Sheehan says.
And you did single fraction, Mike?
No, it was fractionated.
Fractionated, okay.
The other thing from a radiation oncology standpoint is when it's up against brainstem like that, the brainstem's pretty radiation sensitive compared to other parts of the brain. And of course, damage to the pons can be catastrophic for the patient with cranial neuropathies and paralyses and things like that. So getting in enough dose, say like I would like 30 gray and 5 fractions at least, for example, the brainstem probably can't tolerate that kind of dose. I mean, looking at our tolerances for these structures, I've got it pinned to my wall so I never forget them. A very limited volume of the brainstem should get more than 23 gray and 5 fractions, which is not enough to kill tumor. And as you can see, it's right up against brainstem here. So I kind of agree with surgery, or or a whole brain, like I was saying, to try to shrink this down to do radiosurgery later, because that would be very risky on the brainstem to try to treat this up front with radiosurgery, I think.
Yeah. So we did talk to her about surgery, and she was medically a little bit on not the best surgical candidate. She had pretty extensive systemic disease in her lungs and lots of large lymph nodes in her neck. So there was concern about that. We spoke with her about doing surgery. She really was somebody who didn't want surgery. So I agreed. All these points were taken into consideration about the shunt, and also about if we were going to treat this, you know, do we do fractionated, do we do a whole brain? And we did think that if we were going to treat this with SRS, that we would need to decrease the volume and sort of just see what happens, short interval follow-up. So she got treated with single fraction, 12 grays, the 50, and this is her 4-week follow-up. Okay. She actually had a fantastic response, shrunk down to about 3.5 cc's, 2.3 cc's, essentially 80% change in volume. So we were very pleased with this. And at this point, her symptoms of gait instability, discoordination, that sort of almost like tiredness, but not necessarily somnolence, she perked right up, was doing very well off corticosteroids. So at this point, our concern was durability, right? So we've had a great response, but it's a low dose. What's our durability going to be like? So I don't know, Dr. Sheehan, if you, I would love to hear your thoughts on this, but we thought about a little bit of a radiosurgery boost to it. So at that point, go ahead.
It's a great response. The Cleveland Clinic group has probably published the most on this type of approach. You know, I'll go back and say that I think that the brainstem tolerance is a little bit higher, perhaps than that. We did publish a series through the looking at single fraction doses and with brain metastasis in the brain stem, and found relatively low risk of adverse radiation effects when they were intraparenchymal in the brainstem. So I think you can get away with a little bit more. And as you fractionate it, I wouldn't be opposed to fractionating it and doing something like 5 times 5, 5 gray times 5, and seeing what kind of response you got. But you've had a marvelous response. I think at this point, maybe close follow-up is the right thing. You could have a low threshold to retreat if there's signs of progression. But I don't know that you absolutely have to booster at this point, but I share your concerns that 12 gray in a single fraction is probably not going to be adequate. But you've added Keytruda now, right? And you've got some time to see.
Yeah.
And you avoided the shunt that I thought might have been required.
We did avoid the shunt, which was good for her.
Good for you.
And us. And exactly. So we're a little bit concerned about, even this one, its location, as well as this one with the obstruction of the fourth there. So we actually boosted her with 10 grays. So you can see here, at 6 weeks, she got the boost, 6 weeks from the previous SRS. And you can see here, the blue is the outline of the old plan, and here we have our new plan. And actually, clinically, she was doing neurologically very, very well, but like I mentioned, she was a very poor systemic disease condition, so she actually progressed in her lungs and ended up requiring a pericardial window, and she had a lot of systemic disease that ended up leading to her demise, unfortunately. But this concept of sort of like an adaptive radiosurgery boost is an interesting thing that I think perhaps we can sort of consider in some of these patients. You obviously have to choose your dose for safety in a large tumor, large volume like she had in a delicate location with the possibility of needing a shunt, but then perhaps you have a little bit of wiggle room to give a boost if necessary. Or alternatively, perhaps the answer is to wait and see, get another interval scan and then boost if necessary. But I do think that most of us would be concerned about a durable response with that low of a dose. But just, I'm not saying that every patient is going to have this robust of a response. And it's important to sort of, as neurosurgeons, I think that what Dr. Sheehan was talking about, how we need to play an active role in brain metastases care. This is why, you can create different scenarios, and you can have creative ways of dealing with a problem that ultimately, you know, if she did not respond well, we're going to be the ones doing the shunt and we're going to be the ones managing the complications. So I think it is very important for us to have a very active role in the care.
I know you've had a great response and, you know, really interesting and challenging cases. If you look at the single fraction radiosurgery history and, you know, what we were using for, what we currently use for metastatic lesions, we were using to treat meningiomas and pituitaries and acoustics with 30 years ago. We just need to work together to come up with a dose and fractionation scheme and treatment algorithms that hopefully doesn't take 30 years for brain metastasis patients to work out. But you've shown that there's going to be more than one option here with all the cases that you presented and the few of the ones I've shown. And so I don't think we're going to be wedded to a single dose and a single fractionation scheme. But we'll need to come up with some that sort of systematically gives us a roadmap to treating these patients. So, but very interesting cases. Thanks.
Thank you.
There looks like there was a question.
Oh, yeah, one question was, when you have a significant amount of blood in the metastatic lesion, how does that alter your SRS planning?
Well, from my standpoint, if it's within the tumor, and if you think that is potentially aspiratable, you could certainly aspirate. I've aspirated cystic tumors with some degree of hemosiderin or blood products within them to decrease mass effect, and then treated the cavity with resection or treated the collapsed metastasis with radiosurgery. But alternately, you can just do single fraction or hypofracture radiosurgery and treat the hematoma too. And I don't know that it's necessarily a complicating feature. I wouldn't exclude the hematoma. I would just treat the entire thing.
Sure.
My pearls on those, what I always teach the residents, they tend not to shrink after treatment. So they tend not to respond as quickly. So I think about surgery in them much more commonly, especially if they're causing symptoms or at risk of causing symptoms. Yeah, so, you know, treating the blood, I always try to, unless it's like a big area, and then you have to think about benefits versus risks. But there was one other thing I was going to say. I'll say it when I think of it.
Okay. Well, we're over time, so I want to thank Dr. Sheehan especially and the rest of the panelists for giving us your time tonight. That was a great session. I think it's going to help many people, both neurosurgery, radiation oncology, and oncology. So everybody, please stay safe, and we'll talk to you guys soon.
Thanks very much.
Thanks, Jace.
Honored. Bye-bye.
Take care.